Thank you, Doctor. Thank you. Next is MP Sonia Sidhu.
Thank you, Chair. Thank you, all the presenters. I want to ask Dr. David, my question is that you mentioned the prescription, opioid prescription to the physician. What kind of restriction need to be done on when the doctors are prescribing opioid prescriptions?
So what kinds of prescriptions should be implemented for physicians? You'll get very different...
So what kind of restriction need to be...
Restrictions?
Yeah, on the physician when they...
Are you asking what restrictions I would advise?
No, any preventive measures, like can you talk about that? You said 1 in 8 deaths involved in Ontario.
Yeah.
So what kind of preventative measures you are thinking, like the physician cannot prescribe the higher opioid
I think there's slightly different constructs, but from the prescribing perspective, I mean, I think, you know, as a physician, I am conditioned to want to help my patient, and I see pain all the time, and I'm scared of the other drugs, and I've become comfortable with opioids because of what we've been taught, much of it untrue. What I'm saying is that I think physicians need to be re-educated, de-educated about these drugs.
What kind of education, like, do you think, what kind of education need to be?
Education should focus on the fact that the goals of a drug are to impart more benefit than harm, and opioids very frequently don't do that. I mean, they can in some patients in the long term, but the higher the dose goes, the less likely that is to happen, and that's why I think doctors shouldn't be allowed to prescribe ridiculous doses, 200 or 300 milligrams. It's inconceivable that someone is benefiting from that. And I also think that these high-dose formulations that are out there, that like the Oxy Neo 80 and the high-dose fentanyl patches, when they are used as directed, you exceed the threshold dose from the old Canadian guidelines, the dose above which it's very likely that harms exceed benefits. I mean, that just shouldn't be happening, and yet it still is. It's a, you know, it's a cultural thing now. We've been doing it for 20 years, and we have to stop doing it.
Okay. Mr. LaBlanc, you said we need to educate our kids for harm reduction. What age need to be? Is it in elementary school or in a middle school?
Well, I see it, at least in Ottawa, children as young as 13 even getting into fentanyl. There seems to be no progression where when I was a youth, people who'd started at marijuana and then alcohol and kind of progressed their way up. They're starting at fentanyl and these hardcore opiates at a really young age. So yeah, I would say junior high school, you know, grade 7, grade 8.
Okay, thank you. And Ms. Lapointe, you said language, and is there any strong language you said in the heroin? Did it any impact on the crisis? Is there great impact, the language you said when, can you outline any other example how language and definition have impacted on the crisis, which is BC?
So what we have heard, and again, I'd like to emphasize before I answer that, we have a dearth of research in this area. So we do not have evidence across the country as to exactly who's dying, when they're dying, why they're dying. So we don't know, for example, how many people who are currently dying were prescribed opiates. If you're going to implement evidence-based solutions, you need evidence, and we do not have that. And I would certainly call on this committee to seek some investment in the research. So to answer your questions, one of the things we hear anecdotally from those who are working with those who use illicit drugs is that the language around stronger drugs, more powerful drugs, will cause a certain segment of the drug-using population to seek out those drugs. So what we're talking about is people who are now actively seeking fentanyl because it's a better high, because it's stronger than the heroin they've been using, for example. But I also want to be clear that the drug deaths that we're seeing in BC are not just opiates. Cocaine is also often involved. Alcohol is often involved. And again, without, we are starting to attempt to do that research to pull out what are the different substances, but without knowing exactly what substances are killing people and how they started to use those substances, I would argue that we really can't implement any meaningful solutions.
Okay, thank you. I want to pass my time to Mr. Strag.